the next case is a patient with a very old woman who was admitted in the geriatry department 2 days ago with painless jaundice since 3 weeks and weight loss of 10 kilos over the last 3 months. You see her past medical history, and we did a CT scan which revealed a huge pancreatic mass in the head with dilated bile ducts, extra and intrahepatic ducts, but unfortunately there was also liver and lung metastasis. So we are doing an ERCP in this patient for palliation. So we are using a TGF 180 from Olympus. This is a 3-lumen sphincterotome from Cook. And you see that on this Jaguar we have already preloaded a torque device just in case we need to have some guide wire manipulation. Pull back the wire. We are in the second part of the duodenum. I will lift a little bit the sphincterotome, and we will try to catch the papilla at 11 o'clock. This should be a good position. Well, what about that? The small injection there. You see that we like to inject a little bit just to see the direction we have to follow. But there, Sonia, you can probe a little bit. Avance maintenant ou jamais? Okay. There we are. Are you in the push a little bit? You have a resistance? You think that we are in the pancreas. Well, I'm not completely sure, but you always have to be confident in your assistant. So we will lift again. You see that I always try to be a little bit more facing the papilla that I am. And this is 12 o'clock, might be good. Inject a little bit. We can probe a little bit with the wire, always very gently, but we are more going towards the pancreas again. So when you have the pancreas, always try to go out of the papilla to repeat the cannulation. Here we are probably in the common sphincter. We can make a small injection. Okay. And there you see that Sonia is pushing a little bit, but I have to be more stable with my catheter. Okay, like that. Are we inside? No. Détends un peu. Okay, I will release the sphincterotome. I turn a little bit to the left and see, like as usual in some pancreatic cancer, the position is a little bit uncomfortable because your stability is a little bit less than in a patient without a mass or a tumoral mass. What's that? Avance un peu. So you see that it's a combination of the work of your assistant who probes a little bit. You have when your assistant is pushing the wire a little bit, of course you have not to push on the papilla, otherwise you will increase the angle of the so if it doesn't work like that, I will start again. I take another position. You see that I'm turning a little bit the side wheel of my scope, which will give me a better position, but which will decrease my stability, of course. So I have to find the good balance. And then we will lift the sphincterotome. Tourne un peu à droite. Okay, that's good. So this is 11 o'clock. So this is really the position I like for biliary cannulation. The problem is that I'm in trouble to stay there, like that. Okay, here we are. And we will inject a little bit. You see that wire-guided cannulation or injection is a combination very often, where you can take advantage of both technique. Yes, there we are. There we are. We should be close to. You see that the tip of my sphincterotomy is inside. I have to turn a little bit to acquire some stability there, and then Sonia can push a little bit more. Of course, trying not to destroy the papilla, because this is the problem with the guide wire, that we will. Of course, when I push like that, I create a S shape. And if I want to correct this S shape, I have to release the sphincterotome a little bit, to turn a little bit to the left. But when you are not stable, when you turn to the left, as you see, you have the risk of losing your position. Where are we there? I still believe that we are not far away from the pancreatic orifice. Sometimes in stricture which are in the common bile duct close to the papilla, of course the cannulation can be a little bit more difficult. We can inject a little bit there, just to see what we have, being careful not inducing a submucosal injection, of course, which is not yet the case. And then I will come back again, because if we don't have a selective cannulation with a guide wire and we don't have any injection, that means that it's often better to come back out of the papilla and to start again. You see that there is a small submucosal tumor in the third part of the duodenum, which is probably a lipoma. Tourne un peu. It's important also to look at the aspect of the papilla. You see that the papilla is going a little bit to the left. So, détends un tout petit peu, okay. And there I'm working very, very gently there. We can inject there, because there I'm sure that I'm not impacted. We don't have anything at the injection. Of course, we don't expect to have too much during injection because we have a stricture in the bile duct. But this is not bad. You see that I'm probably at one of the first angles. So there I have to work on my side in this, in this difficult cannulation, détends. You see that Sonia will release the sphincterotome. And I'm trying to go a little bit more on the left side from above the papilla to make what we call the chausse-pied in French, this the horse shoe, the shoehorn maneuver. You see that I'm trying to turn the shaft of the scope. There we can get a very small injection just to see, just in case, what we could have. Maybe we had a small injection above a stricture there, but I'm not sure. And then I can come back in this direction. I'm sure that one of you will ask me when I will think about a pre-cut in a patient like that. But I would probably think to a pre-cut in a patient with a CBD stone. I'm really not in a hurry for doing a pre-cut in a patient with this kind of stricture, because when I will do a pre-cut, I will come on the tumor itself again, and it will probably not very much help me. So as long as I can try to get the normal anatomy, I will work a little bit. So you see that it's really a combination of two of the work which is done by two people. Here is Sonia, who is doing most of the work. If you have the fluoroscopic image, she has the feeling that she's in a structure. So there she will release. I will follow her there, okay? Here we will inject to see if we are into the bile duct or into the pancreas. We are in a structure. This should be the bile duct, but you see that we are stopped by the stricture. So we obtained a deep cannulation, which is already a good thing. And now, as you see, this is not my work, definitively, but the work of Sonia. She's going to the cystic duct just to make the thing a little bit more difficult. And then we will inject a little bit. I cannot go up because we have a tight structure there, you see. And I want to be sure that we are in the bile duct, which looks to be the case. There we are. Inject there. Okay. Inject there. Yes, you can inject there. Okay, we are with a 3-lumen sphincterotomy, probably still in the cystic duct there. Do you agree with that, Jacques? Or?
Yes, Jacques, I think now you can clearly see that that's a cystic duct. Let's hope that you've not passed from the stricture into the cystic duct and that the CBD takeoff is also in the stricture, because that will be difficult then.
So what I will do at this stage, probably to make the thing more comfortable, is to perform a sphincterotomy. Then we will be a little bit more comfortable. I'm not afraid about doing a sphincterotomy because, as you mentioned, either the confluence between the cystic duct and the common bile duct is into the stricture, but it's surely not below. So I just want to secure my access to the bile duct. So we will stay there with the guide wire. I'm pulling back the sphincterotomy, okay. And then I will perform the sphincterotomy. Je peux avoir un petit plus copain là? Ou en tout cas l'endormir un peu plus parce que ça commence à bouger. Je vais tout perdre. Voilà. Yes, ok. Voilà, ok. Here we are. Okay, you see that this is probably not the ideal position for the sphincterotomy, but I always, even if I start without holding the scope, I always come back with my hand on the shaft of the scope. This is the best way to control the direction of your sphincterotomy. And because I probably do not need a very large sphincterotomy. I always do a sphincterotomy when I place a metallic stent. Also, I know that this is not clearly established that it's mandatory. I'm much more reluctant to do a sphincterotomy when I do when I place a plastic stent, especially for benign indication. But I think that here the sphincterotomy is also part of the treatment by securing the access to the bile duct. So now I will try with this sphincterotomy to follow the guide wire into the stricture.
Jacques, we're going to leave you for a minute to introduce the next case, and then hopefully we'll be back to you after you find the access to the CBD.
Thank you, Jacques. You are with us, Jacques. As you suggested, the bifurcation between the cystic duct and the common bile duct was inside the stricture. So we had to pull back the sphincterotomy, and Sonia was able to push a guide wire deeply into the common bile duct. So we have a distal stricture in this patient. We have a cystic duct which is involved by the tumor. So my choice will be for I already did some brushing to get some cytology in this patient. Also, this is more theoretical. We already have an histology, but I think that it was just for the demonstration, but you left us during this time. So now we are placing a self-expandable metal stent. We have chosen an evolution from Cook. This is an open mesh stent, and this is on purpose that I choose an open mesh and not partially covered, because I think that even if there is a little bit more duration of patency of the partially covered, I think that in this lady this will not be essential, but also because we have the bifurcation between the cystic duct and the common bile duct, which is inside the tumor. So I don't want to occlude completely the cystic duct with the risk of cholangitis. In all these cases, I almost always choose the 6 centimeter. I think that the 6 centimeter has an advantage over the 4 centimeter in terms of stability. And with the 6 centimeter, you are always below the hilum in case the patient would have been operable. Again, in this patient, the patient is not operable, but what we don't want, of course, is to cross the hilum. I think that the fluoroscopy is probably not really obvious now. I don't know if Enrique, who is our excellent radiologist, can show that a little bit better, but you see that here I'm really covering the stent. So this evolution has some features. You see that I see the junction between the distal meshes of the stent and the pusher and the catheter, the yellow catheter. So this is the area that I want to have under control during the whole procedure. And you see that Sonia is...
Jacques, can we just... we don't have endoscopy, so can we have endoscopy, and can you just repeat what you were saying in terms of where your eye is focusing on? Yes, we have endoscopy now.
Okay, you see my eye during the release is focusing on the junction between the distal mesh in black and the yellow catheter. So when Sonia will start the release just by pressing the button like a pistol, right? You see that I have to pull back the sheet just to maintain this part under my vision. And this will be my major control. If we can come back to the fluoroscopic image for 1 second, you see that the opening already started. I have, of course, the fluoroscopic control, but when I'm sure that the proximal part is in a good position, I can switch to the endoscopic image. Let's go. And this will be my single control during release.
So Jacques, you're pulling back, while Sonia is opening up the stent, you're pulling back the stent, right, to maintain it in position?
Especially at the beginning. Once we have started the release, I think that the need to pull the catheter is probably less. But in any case, you have to follow the catheter because, if we can show the hands of Sonia, what's she doing when she's pushing on the pistol? She's advancing a little bit the stent, and you see that there is also a point of no return because we can also reload the stent. But I think that we have passed the point of no return, which is there. So it's almost passed. And never forget that with this stent, you have to remove the small attachment, the distal attachment at the end. So pull on it. Otherwise, the stent will remain attached to the introducer. So now we come back to the endoscopic view. I open my elevator completely, of course, and then I continue the release. And we see that it's quite stable and the stent is in a position which is, I think, okay.
Excellent. Thank you very much.
Sonia and Jacques, this is Stefan. I would like to congratulate you to this outstanding case, and we thank you because that was a case very interesting, difficult cannulation, placement of stent, and we want to say thank you and bye-bye to you, your team. It was outstanding. We have applause here in the room for this wonderful teaching presentations, and thank you so much, and thank you for your great effort to come on a Saturday for us here in Zurich to teach us ERCP on the highest level. Thank you so much.
Thank you very much. Bye.
Thank you
Bye,
very
guys.
much, Stéphane and Jacques and all your team. Always nice to be with you, even from Belgium. Bye-bye.